Good evening, everybody. I'm Dr. Pratik Kambe, Chairperson for the AMOG's Endocrinology Committee. Warm welcome to today's event. Today, unfortunately, we've had to shift our regular 2 to 4 p.m. slot to 4 to 6 p.m. So apologies for the inconvenience. And let me begin by offering my gratitude to the AMOG's office bearers. Next slide, please. I'd like to express my gratitude to our AMOG's president, Dr. Nandita Palshetkar. Madam is the current president of AMOG's, the immediate past president of FOXI, also served as a president of IAG and Voice Society in the past, current vice president of ISAR. Thank you, ma'am, for your blessings and your guidance and for always supporting us in all our academic endeavors. Next slide, please. I would also like to express my gratitude to Dr. Arun Naik, who is the secretary of AMOG's. Sir is also served as the president of the Voice Society in the past, a fantastic vaginal surgeon, is distinguished academic expert on so many issues in his own right. Thank you, sir, for your support, your blessings, and your guidance in all our endeavors. Thank you so much. Next slide, please. At this point, I'd like to express my gratitude to the ICOG office bearers, our chairperson of ICOG, Dr. Uday Thanawala, the secretary of ICOG, Dr. Ashok Kumar, for granting us the ICOG credit point for today's event. Next slide, please. Today, we have a galaxy of stalwarts from all over the country, not just Mumbai and Maharashtra, but also the rest of India. We're going to have a very nice sort of semi-formal panel discussion on treating myomas, specifically the options that we have and the recent advances in that particular field. It's a dry, boring topic. We'll try and make it interesting, and hopefully we'll have some very good, interesting take-home messages, unique perspectives from all over the country on how this common condition is diagnosed, treated, and ultimately managed to the satisfaction of our patients. Next slide, please. With us to discuss all these wonderful issues, we have Dr. Asha Jain. Madam is the director of SMSA Hospital in Raipur. She is the medical director of an NGO, Cancer Prevention and Relief Society in Raipur. She is an elected member of the Chhattisgarh Medical Council, also served as the secretary of IMA Raipur, and she is the president of the Raipur OBGYN Society for several years. Also served as the past president of Rotary Club of Raipur North. She does a lot of academic events in her own society, and she'll be very soon contesting for post as FOXI chairperson. We wish her all the very best in her endeavors, and we hope to see her as not only a local stalwart but also on the national stage very soon. Next slide, please. We are glad to welcome Dr. Nitumoni Gogoi. Madam is a senior practicing OBGYN since the last 16 years. She's done her MD from KMC Dibrugarh, the Assam Mayflower Hospital, and the Margari Hospital. Thank you so much, ma'am, for joining us. She was introduced to me incidentally by Dr. Arun Madhav Borua last year, and she was in one of my panels, which was on an aesthetic topic, if I remember correctly. And it was so wonderful that I thought we should also invite her to one of our panels on a gynec topic as well. We are also privileged to have with us Dr. Seema Varshni. Madam is a consultant obstetrician and gynecologist. She hails from Ghaziabad. She is served as the president and the secretary of the Ghaziabad OBGYN Society. Received the Wonder Woman Foxian Award in 2019. Currently, she is the secretary of the UP West chapter of ISOPAB, and she has also invited me to several of their events in the past. Thank you, ma'am, for considering me. And at a different time when we used to have physical events, I remember we had some fantastic memories of visiting Ghaziabad with our then FOXI president, Dr. Nandita Palshetkar. Thank you for those lovely memories. Next slide, please. Dr. S.P. Jaiswal from Lucknow is also from ISOPAB, and she unfortunately will be unable to join us today because of a death in the family. She sends her apologies. We wish her well and safe journey. Next slide, please. Dr. Julia Agarwal is a professor at the Department of OBGYN at the Gandhi Medical College in Bhopal. She has several publications in national as well as international journals. She's been faculty at various AICOG conferences. She's a street trainer for CAC and STI, served as the secretary of the Bhopal Society for consecutive years. She's also a group investigator in an ICMR project on anemia and hemoglobin levels, and she's served as a member of the OPSI Midlife Committee. Several awards to her credit, including Best Paper Prize and Best Poster Prizes. Thank you so much, ma'am, for being with us. Next slide, please. We are also delighted to have with us, if I can say, somebody who hails from the same geographical location as myself, Dr. Deepali. She is an associate professor in the Department of OBGYN at Sion Hospital. She's also a consultant at Jupiter and Curie Hospitals in Thane, recipient of the TOGS Young Scientist Award in 2020. Despite her appearance, she is also an MUHS recognized UG and PG teacher. She is not a student yet, and she's also currently the chairperson of the Public Awareness Committee of TOGS. Thank you, ma'am, for joining us, and we hope to have a delightful discussion.
Thank you, sir.
Next slide, please. We are also privileged to have with us Dr. Santosh Jaibhaye. Sir is an avid fitness freak. He is known to run several marathons every year, and you can see in his picture behind him are all the medals for all the marathons that he has completed. I'm just going off the beaten track and introducing the extracurricular activities first, because all of us are very good at academics, but there are very few of us who know to have the right balance in life, know when to say enough is enough, we've made enough money now let us look after our health and our society's health as well. Sir has done his PG from KM Hospital. He is a practicing OBGYN and freelance endoscopic surgeon from Navi Mumbai. Recently completed a diploma in gynecology endoscopy from Keele School, and he's a member of several professional organizations. Currently, he's the secretary of the Navi Mumbai Society of OBGYN. Has the credit of starting the first advanced laparoscopic surgery center in Kamote, which is a small area in Navi Mumbai. I don't know if you're aware, but kudos to him for bringing on this advanced specialty to even the Mufasil areas of Mumbai and Maharashtra. Next slide, please. Dr. Rekha Rajesh hails from Hosur, which is a small little place on the outskirts of Bangalore. I had the privilege of meeting her in person a couple of years ago. She's a very active person as far as activities are concerned. She was the secretary of the Hosur Society. Also has a diploma in reproductive medicine from Germany and London. He is in FICOG, also has a diploma in cosmetic gynecology and several other trainings to her credit. Thank you, ma'am, for joining us. Next slide, please. So that's about it. And with the formal introductions out of the way, I would like to welcome all the panelists. Thank you so much for giving your precious time. We are going to have a very simple, straightforward panel, which is case-based, and we'll like to see how each of you will tackle this particular set of cases in clinical practice. And we are going to be talking about myomas today, a very common gynec condition and something which is very tempting to all of us as surgeons. Do we operate or do we not operate? Is it in the patient's best interest, or is it only in the interest of our bank balance? Let us try and find what is the best way forward, what are the best practices for each of these clinical cases. The first lady is 25 years old. She is unmarried, works as an IT professional, wants to get married next year. She has no complaints as such. She is in good health, healthy. And during a routine ultrasound examination for medical fitness, she's been diagnosed to have a 3 centimeter intramural fibroid. Somebody has recommended her, we will not say who, to undergo surgery for the same, but she's come to you for a second opinion. Dr. Rekha Rajesh, ma'am, how would you like to counsel this lady? Should we operate on her because she's from a well-to-do class? She trusts you because she's come to you for a second opinion, obviously. Is surgery really mandated? She is asymptomatic. What should we say?
Good afternoon, sir, and thanks for giving me this opportunity to join this esteemed panel. I'd prefer to handle her with a conservative management and not jump into do a surgery. And since it's only 3 centimeters and intramural, based on the FIGO classification, we can still do medical management, give her a course of medical tablets, and then probably when she's planning her family, reassess her and then decide how to take her on further.
So as of now, you would think it is best not to interfere.
Yes, sir.
Leave well enough alone. Don't dig your grave. Don't put your foot in it. That is the short message that you would like to give our audience.
Yes.
Dr. Seema Varshney ma'am, this patient is from the IT background. So obviously she is going to read up on Google and find out a lot of confusing information about fibroids. So if she asks you that she is worried that this may prevent her from, number one, getting married, or number two, later on after she gets married, from conceiving, how would you like to address these fears?
Good afternoon, everyone, and thank you, Dr. Pratik sir, for giving this opportunity for to be a part of a very good, interesting panel. This lady, because she is asymptomatic and this finding is very much accidental. She is having 3 centimeter intramural fibroid. We would counsel her that this is a very common condition and you should not get fear or you should not be scared for this. And you should do one thing that is very much important, that is wakeful watching. And you can do your follow-up by getting ultrasound every 3 to 6 months. And right now, you require no such treatment like surgery. We can do your conservative management. And one thing is important, you should keep in mind, if you get, keep your marriage earliest and you plan your pregnancy at earliest, as in following years, if the fibroid grows or there are symptoms arises, then you can find some difficulty in getting pregnant, or the fibroid can complicate your pregnancy. So only thing is to be done. We would counsel her ki you should get married as soon as possible, and as soon as possible you should plan your pregnancy. And this is not going to be cancerous. It is very slow growing process, and we can keep its watching by getting ultrasound and taking consultation.
Dr. Juhi, I see you nodding. Do you think that this is the right approach? Can we guarantee any patient that the fibroid will not grow and that will not preventing her from conceive? Is that an assurance that we can give a patient? Can you please unmute yourself?
Unmute
yourself. Yeah. Definitely, it is not sure whether it will grow, whether it will remain of same size, whether it will. But yes, you can always counsel the patient, as Madam said, that you have to go for a follow-up. Go for a follow-up. Don't get panic. Fibroids are usually the most common tumor. They are womb stones of womb stones. They are called womb stones. They lie as such. They may be asymptomatic, but if you become symptomatic, definitely there is a treatment. And of course, as Madam said, that try to get pregnant as soon as possible once you get married. That may solve your problem and even your anxiety. So I totally agree, ma'am.
Panelists are all in agreement that this is one case where just watchful expectancy, a serial ultrasound, and a good follow-up with a proper counseling, the friendly neighborhood gynecologist, that is your role in this particular case. All that we need to make our patients aware is that fibroids, just like septal defects, atrial septal defects, for example, are something which are very common. These may be seen in up to 5 to 10% of the normal population. In many patients, they are asymptomatic. They may grow. Nobody knows how fast they'll grow because it's unpredictable. All that we can do at this stage for a 3 centimeter intramural fibroid is that you just do a serial ultrasound monitoring and hope and pray that it doesn't become a submucous fibroid, which will lead to space occupying lesion problems, compression, abnormal uterine bleeding, and of course, issues with conception. Treatment is simply to be recommended if the patient is symptomatic, and this is not going to prevent her, number one, from getting married because it's not something which is a cancer, and hopefully this will not lead to fertility issues in the future. So I think we are now warmed up and we are off the mark. Let's go to just put this up because sometimes we like to discuss what is the classification for fibroids. I think most of us are aware that we need to be following the palm-coin classification. This is from the original paper published by TOG in 2011. And if it's a submucous fibroid, that is when we would be more worried than for an intramural fibroid. So let's look at the next case. This is a 28-year-old woman. She is married since 3 years. She has one child. She's conceived spontaneously, and she wants to plan the next pregnancy after a couple of years. She now has heavy menstrual bleeding, so this is a symptomatic patient. Her current period has started about 3 days back, and she's presented for the first time to you with severe abdominal pain, cramping, and history of choking, and pads pulling. We did an ultrasound. There are two fibroids. One is subserous, which is 3 centimeters. The second is intramural, which is 4 centimeters in diameter. Currently, what is worrisome is that she has severe bleeding and she has abdominal cramping. Dr. Nitumani, would you like to take this and start the discussion? How do we approach this patient and arrest the acute episode of bleeding? Please unmute yourself now. You need to unmute. Bottom left.
Am I audible now, sir?
Yes, ma'am. Perfect.
Yeah, good afternoon, and good afternoon, the esteemed panel, and thank you, sir, for giving me this opportunity. So, this is a lady who has fibroids that are symptomatic in terms that it is causing her heavy menstrual bleeding. And secondly, we know here that she is not desirous of pregnancy right at this moment, but she wants to retain her fertility. That is, she is planning for a conception after a couple of years. Now, since she has presented with heavy menstrual bleeding, we have to address that issue first of all. So, I would like to give her as the first line of management tranexamic acid and NSAIDs to address bleeding, and also till the time a definitive management is planned for her. And if I see that the NSAIDs and tranexamic acid are controlling her menstrual bleeding well, then we can continue with this regimen for next 3 menstrual cycles. And then after that, we can switch over to combined oral contraceptives that will address her both issues. It will control her HMB as well as it will give her a contraceptive effect. And the other option is that we can also give her high dose progestins, that is northisterone acetate, which we can start from her day 5 of the menstrual cycle until day 26. That regimen can also be given to her. Now, secondly, if this lady is not wanting to have any oral hormonal pills, then we can give her the option of LNG IUS, which will again treat her heavy menstrual bleeding as well as give her contraceptive effect. And then we also do have the other medical options of giving her selective SPRMs, selective progesterone receptor modulator.
So we'll come to SPRMs a little later, ma'am, if you don't mind. There's another case where we'll discuss SPRMs, but I think you put it very beautifully. For the acute episode to be arrested, we need to obviously administer some styptic agents like tranexamic acid. It's widely available. Most of the time, if the patient calls you on the phone, if it's a patient who is known to you, then you would probably prescribe it on the phone only these days. In the old days, we used to prescribe something called as gyne-CVP. Now we have switched to tranexamic acid because it's so widely and easily available. Often patients can get it without a written prescription as well. You would, of course, need to keep her in the hospital for a couple of days till the initial episode has arrested. And to speak on the progestin dosages, I would like to invite Dr. Asha Jain, ma'am, with your vast expertise and so many years of practice. How do you see the trends changing in administration of progestins?
It was only norepinephrine, which people would start with 30 milligram a day, sometimes even more than that. QID also I have seen prescription. And, now I think people have learned how to use them. So the minimum dose and for the correct duration. Otherwise, there used to be prescriptions writing progesterone for 5 days, maybe for 10 days. And then that would stop and the patient would bleed again and she would land up in the second month in a hysterectomy. So that has sort of improved now. You start with progesterones, you can also shift to low-dose pills, and as Madam said, put the LNG IUD, that is also coming up in a very good way. Because this patient has 2 fibroids, but none of them are invading the endometrium. There's no compression on the endometrium. So we cannot say that her bleeding is because of the fibroids. We need to make sure what exactly is the cause of this bleeding. whether it is a hypothyroid condition. We really don't know. The patient has come with complaints only for 3 months, and I'm pretty sure these fibroids did not come up only in 3 months. You know, they must have been there for quite a long time, and it's still submucous. So, as you rightly mentioned, you give progesterone, give it for 21 days in reducing dosage, and you have to, once she stops bleeding, is when you investigate. A thyroid test can be done immediately, a clotting profile can be done immediately. These days, dengue is also one. We've lost one doctor now to it. So, you just get tested that the patient is otherwise no clotting problem and no thyroid problem. And AMH can also be done, because I've found that patients who have a very low AMH, they usually have these progesterone deficient bleedings for a long time. And there's no typical age. People 25, 26, and 30 also have AMH of less than 0.4, 0.5. And they have episodes of such bleeding. So I think that is one thing I would also like.
Thank you, ma'am, for pointing out that systemic examination is also an equally important part of clinical examination. It's good to focus on the acute episode, but we must not forget the basics. Look at the thyroid, look for pallor, if required, treat the anemia. And as you rightly pointed out, previously there was only norethistone. Now we have multiple options available. We also have these newfangled sustained release preparations, which are now easily available. Dr. Deepal, any experience with using the sustained release types of progestins in your practice?
No, sir. I prefer giving norethistone 10 milligram TDS.
Okay.
No sustained release preparation.
And if I may ask, I think Dr. Santosh is the only person who has not answered so far. If you remember, sir, our old textbooks used to say you can give IV estrogens to arrest an acute episode. Now, I have read this in books. Clinically and practically, I have never done it. But now we have good oral estrogens in the form of pure estrogens that are available. Would you suggest something like an estrogen to arrest the acute episode of bleeding?
In my practice, I have never tried fully on estrogen, but I am very confident that the progesterones will take care of the situation, definitely.
Precisely. So now with IV and IM tranexamic acid and a combination of either sustained release or regular progestins, pretty much every episode can be arrested. Yes. And in the old days, when we didn't have such good efficacious agents, sometimes we used to have to take the patient up for a curettage to arrest the acute episode, which almost never we required to these days. Of course, you would follow up this patient after the acute episode had arrested and ensure that she receives at least 2 to 3 cycles if you are waiting for definitive surgery. And this is the intervening time when you would arrest not only the bleeding, but correct the anemia, and you would also address any other medical issues that she may have. I think Dr. Asha Jain ma'am pointed out that sometimes, rarely, bleeding episode may be masquerading as a blood dyscrasia or other issues, and those need to be ruled out with a multidisciplinary approach. Let's go to the next case. This is the TOG algorithm for managing chronic AUP. We've covered that quite in detail. Rarely you can have inherited coagulopathies, as I mentioned, but the most common things we have already talked about. Let's go to the next case. This is a 28-year-old who was married since 3 years. She's trying to conceive since 1 year. Unfortunately, has been unable to conceive. At the same time, she's had excessive bleeding, menstrual cramping since about 3 months. So this is by definition chronic AUP. Ultrasound now reveals a 3 centimeter submucous fibroid. We are going to assume for the sake of discussion that all the other tests are normal and focus only on the fibroid. So let's talk to the endoscopic surgeon, Dr. Santosh, and ask him what does he feel is the best approach for this patient who is presented with bleeding and also with infertility. So this is a textbook case for you, sir. Take it away.
We are assuming that rest all parameters for infertility are within normal limit, and as of now, we are attributing this infertility to the fibroid. Okay. So what I will like to have a 3D ultrasound pelvis of the patient.
Very good.
If not possible, I will try to get a sono
SSG, a sonosalpingography. Yes.
sonosalpingography of the patient to see how much of the part of the fibroid is projecting into the cavity. If it is grade 0 or 1, according to the classification, hysteroscopic management will be a better choice for this patient. If the patient's if the fibroid is less than 50% in the cavity and more than 50% intramural, it will be better to approach this case by a laparoscopic approach. Of course, there are many hysteroscopic surgeons who can take entire fibroid from below, but for an average surgeon who want to be safe, grade 0, grade 1 can be tackled hysteroscopically. Rest, it is better to manage by laparoscopy.
Okay. So since this is a 3 centimeter submucous fibroid, you feel that it would still be pertinent and relevant to do what is called as fibroid mapping with a good 3D ultrasound. If that is not available.
Yes, it
absolutely.
will be better because one thing is if there is not much of fibroid projecting into cavity, we may have to reconsider whether that is really causing infertility or not. It may cause heavy menstrual bleeding, of course, but as far as infertility goes, it is better we map it properly.
So there is one more classification actually, which is a good predictor for what difficulty we are anticipating in doing a hysteroscopic myomectomy, the Lasmar's classification,
yes,
or what we call as the step W, where you see the size of the fibroid, the topography, where it is located in the cavity, the extent of the base, the penetration, and if it is present in the lateral wall. So if the score is 0 to 4, it is a low complex hysteroscopic myomectomy. If it is between 5 to 6, you can consider the pre-op giving some medicines like SPRM or GnRH agonist and then posting the patient for a hysteroscopic myomectomy. And if the score is between 7 to 9, I think this patient should be counseled that she might need a 2-step hysteroscopic myomectomy or an additional laparoscopy or laparotomy procedure for the myomectomy.
Perfect. So I think that brings in focus very sharply the issue of how we talk to our patients and what sort of promises we make. Often we tell patients कि कुछ नहीं है, hysteroscopy से 5 मिनट में खत्म हो जाएगा, सब normal है, कुछ नहीं, you will go home the same day, it's a daycare surgery, without explaining the risks to the patient. So can I ask Dr. Juhi Agarwal ma'am to comment a little bit on how we would like to preoperatively make this patient ready for a surgery and how should we counsel her regarding the risks of any surgery?
Sir, since this fibroid is a submucous fibroid and we have already done her myoma mapping and now we have made ready, we are convinced that yes, we have to attempt a surgery on her. And even we have convinced the patient. But before undergoing this surgery, we have to counsel the patient regarding the risk associated with the surgery and approach of surgery. And also post-operative adhesions, she has to undergo second look hysteroscopy for adhesions. She may land up in a problem later also after myomectomy. She should realize this, that there are chances that she may not regain her fertility later, or at times she may also. So it's a risk for her on her behalf. So that we have to counsel her thoroughly and then we should undergo surgery.
So there are certain issues which the patient needs to be aware of so that we call whatever consent we take as in inverted commas an informed consent. She needs to know the risks of the surgery, the risks of anesthesia, specifically the risks of the procedure, which means that there could be heavy bleeding. It could be that the surgery is incomplete. 3 centimeters is not a very large fibroid. But for you, if you are the operating surgeon, it may be a big fibroid. And on table, you may find that you're not able to complete the procedure in a single step. So multiple sittings may be required. If preoperatively you've not informed the patient that you may require multiple sittings or that you may need an exploration if it's not in the site where we thought it was, then that is something which will leave you in a very difficult position. To put it in a cricketing terminology, you will be on a sticky wicket because post-operatively, if the patient finds out that without her consent, you have opened her abdomen and taken out the fibroid from above, you will be liable for assault and battery. Dr. Santosh, you are also a bit of a medical legal expert. Can you tell us what will happen if we don't take the appropriate consent and operate on this patient just to complete the surgery and save our own face?
See, unless and until it is life-saving, you should not go beyond what is written in the consent. If it is not written, fine, close, end the surgery, let patient come out of anesthesia, explain patient, you can repost her after 2 or 3 days. It is not going to make any difference. What I will recommend here is beforehand, anticipate the things. Take a comprehensive consent that we might face this thing, even though it is less likely, but we never know. We may have to think of these options so that patient is having a complete idea what all are the probabilities and what all things can happen. And if patient is signing fine, if patient is saying that you limit whatever you can do from by histoscopy, finish it off. And if patient is if patient is not ready, or if patient has been not been counseled for extension in the form of laparotomy or a laparoscopy, it is better to avoid, because as far as hysteroscopies go, you can anytime have a 2-stage surgeries, or you can stop the surgery in between. There is no problem. Similar is not the situation in laparoscopy. So what I feel that if we don't have a consent, and if it is not life-saving situation, it is better to avoid.
Absolutely correct. So understand your limits, explain the limits to the patient well in advance, make sure that her caregivers are also there at the counseling session, make sure that whatever consent you take has been clearly documented, and if you have not taken consent for a laparoscopy or a laparotomy, then please don't perform it, because you will be doing that to save your own face, but the patient has not given you consent for the same. I see Dr. Ashajan ma'am wants to add something. Please go ahead.
I object to this line that you put here, ultrasound by a radiologist.
You and I.
So there is a specific reason why I have put that, because we are talking about a 3D ultrasound and fibroid mapping. Yes, while we are very good at doing ultrasounds,
I'm trained to do that.
Absolutely correct. Somebody who is trained to do it is the one who should be doing it. Unfortunately, I do not have that kind of training in 3D ultrasound, and not many people who are OBGYNs would have training in 3D ultrasound, and that is why I have written radiologist. I stand corrected. Maybe that terminology should be replaced by somebody who has appropriate training in 3D ultrasound for fibroid. That is the message that we are trying to convey. Let's take Dr. Rekha Rajesh's opinion. Ma'am, in this particular patient, would you like to do a single hysteroscopic approach, or do you want a combined hysteroscopic and laparoscopic approach? How would you like to proceed? Please unmute.
Yeah. Since she's planning fertility, sir, I might as well do diagnostic hysterolab, evaluate her tubes, because we're putting her under anesthesia.
Very good, excellent point.
And see that the ground is well prepared for planning her pregnancy. And if we are not able to, I would want to prepare her with the analogs and other drugs, so that the bleeding during hysteroscopy is little less, and we can take her forward for planning a pregnancy. So a 3 centimeter hysteroscopic removal might not be difficult, but we should be prepared for the worst, and then prepare her in such a way, and keep our frameworks and maintain, like sir said, within our framework, we should take a proper consent and then take the procedure, and guide her also, saying that, this is done for her well-being.
Perfect. So I think we are all in agreement here that sometimes doing a combined approach may be beneficial to the patient and avoids the embarrassment of not being able to complete the procedure in a single sitting. I remember my teacher, Dr. Nitin Narvekar, who was an endoscopic surgeon since nearly 30 years ago. And 25 years ago, he taught me that sometimes it's better to always put a telescope from above first, view the entire pelvic contents, leave it inside in place in case there is a complication. Make sure that at the end of the procedure, you fill in some amount of normal saline, leave that in the pelvis because that aids the recovery of the patient. And sometimes that may also help to prevent adhesion. Yes, ma'am, please go ahead. Sorry, I interrupted.
Sir, I want to add one thing. Can't we consider selective progesterone receptor modulators instead of surgery? And many a times, if it is type 2 type of myoma, it may recede and the patient may conceive after that.
Yeah, so as far as SPRMs are concerned, the next case is for SPRMs. In this particular patient, where it's a proper 3 centimeter submucous fibroid which is projecting into the cavity, and it is a space occupying lesion which is causing both compression, space occupying lesion like effects, and also menorrhagia. This patient probably will do better with surgery rather than with the SPRMs. We'll come to the issue of SPRMs and what are the advantages and disadvantages in just a couple of minutes. I want Dr. Santosh sir explain to us how we actually do a hysteroscopic myomectomy. Obviously, some amount of expertise and training is required. But what are the surgical principles that you follow when you're operating on the submucous fibroids?
For submucous fibroids, they are better tackled with the help of electrosurgery. We generally prefer using bipolar resectoscope and normal saline as a distension medium, because the side effects and complications associated with glycine are way more dangerous as compared to what we face with normal saline. One thing. Second thing, we have little more leverage as long as we are using normal saline as long as as far as the duration of the surgery is concerned, because the fluid deficit allowed for a normal saline is definitely more as compared to what we can have with glycine before the complication sets in. And a good bipolar resectoscope with loop electrode is one thing which will help us to take out the fibroid in chips. And rest following the principles of hysteroscopy, electrosurgery in hysteroscopy, we can start from one end of the cavity and from the area which is projecting most into cavity, and slowly and steadily we can start resecting the chips and we can take them out.
Thank you. So I think sir has explained the surgical technique quite nicely. Yeah, somebody was saying something.
So if I may add, I think
yeah, go ahead.
Cervical ripening with prostaglandins is better, because obviously the introduction of hysteroscope, and you can prevent injury to the cervix or or prevent perforations of the uterus. When you're
especially if you have a nulliparous patient, it's a good idea.
Yeah,
this
and
particular patient, we don't know whether it is
also.
You like GNRH agonist before hysteroscopic surgery?
Sir, if it's a bigger fibroid, then yeah, it reduces. If the endometrial lining is thin, so visualization will be better, and obviously the operative time and the intra blood loss will be less. Because
that's the theory. Unfortunately, what happens in practice is that your tissue planes are blurred and you don't know when to stop, because the pseudo capsule which is there, that gets obliterated. And we'll come to that discussion when we talk about laparoscopic myomectomy. I just thought I'll mention it here in passing, but we will discuss that in a little more detail a little later. Dr. Seema Varshini ma'am, any further points you would like to add specifically regarding this issue of glycine toxicity, which was briefly mentioned?
I have no experience.
I hope you don't have any experience, because it's one of the worst things that you can ever encounter. Anybody else would like to take this up and talk about glycine toxicity?
Yes, sir. This glycine toxicity, if the surgeon is very experienced and he can finish it within a particular time, then glycine is the right choice. But if they are early surgeons who are just in the learning curve and who would take a little longer time, then saline is the appropriate choice. And also,
so basically, what happens when you have glycine toxicity? What is wrong with glycine, and why were we using it for a very long time?
Yes, sir. It causes a hyperconcentration of the plasma, and then they have some irritability, and then patient goes into a cerebral delirium kind of situation with The high concentrated fluid, increased frequency of urination depends on the volume of glycine used and the level of glycine absorbed. So based on that, there are different stages of presentation, and sometimes patient gets into coma if they are very severe. So the cerebral edema happens, and then patient gets very serious. So we need to keep it in mind that glycine toxicity is to be looked for when we are using, and we have to follow the amount of glycine used and the glycine that is falling off. We need to measure and then evaluate the probable absorption levels, and then treat her or stop when it is exceeding the limits.
Okay, excellent. So I think here what we need to convey is that today most of us have transitioned to something called as a bipolar electrosurgery with whatever electrode, and normal saline as the distension. Normal saline or Ringer's lactate is an isotonic solution. Even if it crosses over via the open bed into the general systemic circulation, it does not have any issues as far as overload is concerned. The problem with glycine is that it is a hyperosmolar solution. If it crosses over into the main systemic circulation, especially when you have a complicated and long surgery like a fibroid resection, it gets absorbed under pressure via all the open blood vessels which are there in the bed of the myoma, and that will lead to a lot of complications because glycine clearance takes place via the liver. So in a very short period of time, you are not only overloading the heart, which has to pump excess fluid which is there now in the systemic circulation, but also the liver, which is going to get a lot of ammonium to detoxify in a very short period of time. Once this happens and the body's defenses are overwhelmed, then you are going to have, as explained, serious consequences like convulsions, coma, and occasionally even death has happened. If this is recognized in time, you can treat the patient. The worst possible issue is that you don't recognize it in time and the patient goes home, collapses, and somebody who is seeking treatment for fertility or menorrhagia lands up with a death because of our negligence. That's the importance of glycine toxicity. All of us should be aware of this, and that is why most of us have now transitioned to normal saline and bipolar electrosurgery. I think we've covered a lot of important ground here. We've talked about the old classification, type 0, type 1, and type 2. If you have more than 50% myometrial penetration, typically these are the patients who you do not want to operate hysteroscopically. Type 0 is the most ideal. Type 1 sometimes requires a combined procedure. Dr. Dipali beautifully brought out the so-called Lasmar's new classification. It's not new anymore because it was in 2005. It's now about 15, 16 years old. Many of us, including practicing endoscopic surgeons, do not use this because it's too complicated and difficult to remember. We still follow the age-old type 0, type 1, and type 2. But the advantage of this classification is that it helps you to identify which fibroids are easily resectable, number one. Number two, which fibroids are going to give you complications like fluid overload. Number three, whether you are going to be able to tackle this in a single sitting or you will require multiple sittings. That's why we should use this more often in clinical practice, even though we feel very bored and we don't want to change. We are happy with the old system. We've discussed the various different principles of surgery, how we operate, how we resect the fibroid. Always cut towards yourself, never cut away, because that is a recipe for disaster. You can easily perforate a uterus, and sometimes a uterus which has multiple fibroids, you will lose your anatomical landmarks. You will not know exactly where you are. You could very easily end up resecting bowel without actually knowing it. A little bit about achieving hemostasis at the end. Dr. Santosh, do you prefer to leave something like, say, a Foley catheter inside to prevent adhesions and achieve hemostasis at the end of your surgery?
Especially if it's a very large area which we have resected during surgery, it will be better to put in a Foley's catheter maybe for 2 or 3 days. and subsequently we can start patient on conjugated estrogen and cyclical progesterone for endometrial revision.
All right. Thank you, sir. So sometimes when you have a large area or you have a broad-based fibroid or extensive resection, putting in a number 9 pediatric Foley catheter, which is inflated to maybe 3 cc, is just adequate to help the walls from collapsing on each other and helping the vessels to be somewhat prevented from opening up. We've talked about bipolar. One interesting paper I found here is that some groups of researchers in Western countries are now doing a combined approach by doing a uterine artery embolization before they post the patient for a hysteroscopic surgery. In the good old days, we used to give either danazol or GnRH analogs, and that used to make our surgery more complicated. With this approach of uterine artery embolization, that avoids the disadvantages of GnRH agonists, and this also reduces the blood flow to the fibroid, making your surgery potentially easier and with less blood loss. As we all know, the shorter the surgery, the better the chance that the patient will have a good recovery and the lesser complication, the dreaded complication of glycine toxicity and fluid overload. Let's go to the next case. This is a 35-year-old lady. She is married since 8 years. She has 2 children, uneventful pregnancies, full-term normal deliveries, completed her childbearing. Now she has heavy menstrual bleeding, 10 to 12 pads per day, hemoglobin is 7 grams. There's a single posterior wall, 5 centimeter fibroid. Let's ask Dr. Nitimoni ma'am what she wants to do for this patient. Would you like to offer her some medical options? Is it possible to medically treat this lady? Please unmute yourself, ma'am. Ma'am, you need to unmute, please. We can't hear you.
Okay, so here is a lady who is 35 years old and has completed a family. She's again presenting with heavy menstrual bleeding to the extent that it has landed her up in a severe anemia. So apart from tackling the fibroids, we have to address her severe anemia first of all. So we have to choose a management option such that we have to buy time to address to her anemia. So I will prefer her to give the various medical management options like GnRH analogs and then selective progesterone receptor modulators also. And during that time, we can give her parenteral iron therapy to address to her to correct her anemia. And the GnRH analog can be given for a shorter time, I mean not longer than 6 months, because the hypoestrogenic effects will otherwise get troublesome for her. And if we are planning for the selective progesterone receptor modulators, those are also very good in terms of reducing bleeding as well as decreasing her fibroid volume size. So checking the all parameters, specifically liver function test, doing a baseline liver function test if they are okay. So we can start on with mifepristone or ulipristal. And after 3 months of therapy, we can assess. We should assess her how much her bleeding is controlled, and reduction in the fibroid volume size. If there is significant reduction in the volume, fibroid volume, that is more than 50%, and the bleeding is controlled, we can stop the therapy. Or if we see that the response is inadequate and the patient is well tolerating the regimen, then we can give her intermittent courses of 3 months each for 4 courses. And at the end of it, if she responds well enough, we can stop the treatment.
I think that's very nicely expressed. Thank you, ma'am, for explaining all the different options to us. I'd like to invite the other panel members also to give their opinions. Let's start with Dr. Joey. Do you think this is a good patient for parenteral iron therapy? We keep talking about parenteral iron for obstetric patients. We talk about postpartum administration of 1 dose before the patient goes home. But we forget about the most basic reasons in cases like this where parenteral iron can really help. Do you think this is a good option?
Yes, sir. We can consider her for parenteral iron, considering we have to stop her bleeding. That means she has been cyclically bleeding profusely. So we should always do treatment so that she may not bleed in her further cycles. One thing.
Okay.
Second thing, we have to see whether this fibroid, which is a posterior wall fibroid, whether this bleeding is, again, we have to do a myoma mapping. We have to grade the myoma, which type of myoma it is. It is just given that it's a 5 centimeter myoma, but this bleeding, it may be due, it may be AUB, any reason, it can be palm cohen, any reason, may not be only AUBL. So you have to treat her accordingly. And if suppose it's not a myoma which is causing bleeding, of course we can go for LNG IUS, we can stop her bleeding, and then we can consider her for parenteral iron therapy, and then it will definitely go, definitely going to help her. But if you don't stop her bleeding, then there is no sense in giving any iron therapy in this patient, and then
Absolutely.
you have to give transfusions, blood transfusions.
So you need a co-prescription. That's something which we would normally recommend for these patients. And this cannot be the primary aim of treatment. A primary aim of treatment will always be to, number one, arrest acute episodes. Number two, maintenance therapy to ensure that, if possible, we can reduce the size and the volume of the fibroid. Dr. Dipali, any experience with GnRH agonists in these kind of patients? Since you brought this up, I'm referring this particular issue to you again.
So, for patients, GnRH agonist should be used as a preoperative bridge therapy. Like if you're asking the patient for a surgery, then, but it is the current recommendations are it should be used only in patients where it's a proper cavitatory submucous myoma, or if you're opting for a hysterectomy. For a laparoscopic or an open myomectomy, since it leads to loss of tissue planes, it would not be my first drug for medical management. I would prefer an SPRM. That is a selective progesterone receptor modulator, either a ulipristal or mifepristone.
Perfect. And can you please tell us how you would administer ulipristal or mifepristone?
So, my mifepristone dose is around 25 microgram per day for a period of 3 months, 12 weeks. And ulipristal is 5 milligram per day, and the single course is of 13 weeks. But in patient, this single course can be given for patients who are waiting for a surgery and you're waiting to build up the hemoglobin of the patient. But there are intermittent long course also therapy, like 4 courses of this 13 weeks therapy can be given to patients who do not want to undergo a surgery. And like Madam said, you have to monitor the base, have a baseline LFTs and monitor it every monthly, because it is definitely contraindicated in patients of severe liver disorders. And there are other minor side effects of ulipristal, like it causes headache or breast pain. And there is something called as progesterone receptor modulated associated endometrial changes. It leads to endometrial hyperplasia. But what is seen is almost 2/3 of the patients, this changes reverse after stopping the therapy after 6 months. So they are not really significant, those changes.
Let me ask Dr. Asha Jain, ma'am, is ulipristal available anymore?
No, sir. Ulipristal is not available anymore.
Okay.
So that is
can you tell us why is it no longer available?
Means it's because of the effects on the liver.
Yes. So it is rare, as Dr. Dipali mentioned, that liver issues may be rare.
One experience of mine, sir. I did she was a relative with multiple fibroids. She refused any surgical treatment, wanted a child. So I gave her 13-week cycles of ulipristal. The size decreased, but it was still big. Then she went for another 2 cycles of mifepristone. And then her fibroids were almost gone. You know, you couldn't find them on ultrasound at all. She got pregnant. But when I did her cesarean section, her whole anterior wall of the uterus without an anterior placenta had huge blood vessels. It was not an anterior placenta. Means it was like what we see placenta accreta spectrum, that kind of vessels on the anterior wall of the uterus without an anterior placenta. It was a horror to operate. I had to give her 5 bottles of blood. So, you know, giving these drugs is all good. They work, but you don't know really what's going to happen. And one patient had come after taking ulipristal, nothing happened to her. But when I opened her abdomen, she, you know, there was no connective tissue. The bladder was like we do in a Verdines. The bladder was just hanging like that without any connective tissue. It was really, really very bad. So we give drugs because, we think ki, theek hai, theek ho jayega, the patient will avoid a surgery. But we really need to read about the side effects and measure our own experience, what is actually happening to the patient.
So for patients who are going to ultimately require a surgery, maybe these agents may not be so efficacious and you may face a more complicated surgery than you anticipated in the first place. That being said, to tide over a short crisis until the patient's hemoglobin is built up or socially it is possible for her to undergo a surgery, there are no lockdowns and the pandemic is over, then probably for that small short period of maybe 3 to 6 cycles, you can try some of these medical agents.
So
Dr.
one
Rekha
question
Rajesh,
I
I
would
wanted
like
to
to
ask you.
ask you just once. How many
Yes,
of you have actually had a problem of bleeding with a 5 centimeter posterior wall fibroid? If it is not pressing on the myometrium,
That
then
is what.
how many have you actually had a problem of such bleeding?
Usually only pelvic heaviness. They always come with मेरे को बहुत भारी लगता है. They say it like this. So they never complain. If at all it is symptomatic, it has to be submucous.
so this is the whole issue with large size fibroids. Sometimes the report says that it is intramural or they say it is subserous. It's only when you do a proper ultrasound with 3D
3D
and fibroid
ultrasound.
mapping, that is when you will realize that more than compression, these also give rise to menorrhagia. Let me go to Dr. Rekha ma'am and ask her, uterine artery embolization. We talk about it so casually because we come from large metro cities. Do you think it's easily available? Do you think there is a lot of expertise amongst radiologists in using this? Just the theory, cannulating from the femoral vein, reaching all up to the uterine vein and uterine artery. It's such a complicated procedure. Can you tell us a little bit about it?
Yes, uterine artery embolizations are in my town. We don't have any interventional radiologists, so I have to send them to Bangalore and to bigger
Problem
centers.
solved.
Yeah, but the thing is, yes, I've got two patients had got it done by choice, and it's a little bit expensive. And then at the end of the day, it is not, the outcome is not as what we expect. So sometimes it is not very successful, and then we need to go back to either medical management or surgical management. In my experience, this is what I have seen of uterine artery embolization. In both the patients who had gone for it had to go back for a hysterectomy post 6 months.
So not very good experience as far as relief of symptoms is concerned, and probably we would say that operator expertise is very important in these cases. Again, accessibility and availability is a major issue, and that's specifically why, even though you are from the outskirts of Bangalore, I wanted to ask you this question.
Yes.
Those of us who
Costing
come from
also
places
matters,
like
sir.
Bombay or Delhi, we just take it for granted. हाँ, कुछ भी uterine artery embolization का thing. Every day there is an advertisement in a newspaper talking about either UAE or MRI focused ultrasound, and patients think हाँ बहुत easy है, करवा लेंगे, fibroid को तो निकालने की जरूरत नहीं, operation की कोई जरूरत नहीं है, बहुत advanced mechanisms आ गए. Dr. Seema Bashne, I wanted to ask you, this MRI focused ultrasound, have you used it in clinical practice? Do you find that it's useful?
Sir, here in our practice, patient comes with fibroid and she has got all the knowledge and she says just she has completed her family. You just take out my uterus. You do my hysterectomy. So number of times we are doing a hysterectomies, and if she knows or we counsel her ki you go and get her this thing, that is very, very difficult to counsel here. अपने मन में here it is set here कि we have to go under hysterectomy only. You take it out and all things gone.
So the uterus becomes an appendix after childbearing is over. That is the message. That patients want to give us. और इसको निकाल दो. That is the permanent solution. Yes. Unfortunately, sometimes we encounter these issues in clinical practice. Dr. Nitumuri, do you have any of these so-called modern availability in your area where you practice? Embolization and MRI. Would you like to comment? Please unmute yourself. You will need to unmute yourself. We can't hear you.
So may I add something?
Yeah, go ahead.
Yeah. Sir, at Sion Hospital, we have both these facilities, uterine artery
Alright.
embolization as well as MR focused ultrasound. So
Okay.
the MR focused ultrasound right now is in the, they're just recruiting patients and not many patients are willing for it. But yeah, we had a personal experience of doing a uterine artery embolization for a patient who had submucous fibroid, not willing for a surgery and with severe menorrhagia. And later on, when she shed off the fibroids in bits and pieces over a period of time. And later on, when we followed her up after 3 months, the fibroid had disappeared completely. It was a proper cavitatory submucous myoma. And then later the patient conceived also, but at the time of the section, the placenta was adherent at the site of the... So that is there. An MR focused ultrasound. So the cost is a big issue. Not many patients are willing for this. And the disadvantage of this procedure is only one fibroid can be tackled at a time.
Plus the disadvantage in this particular patient, if I may remind everybody, it's a posterior wall fibroid. Posterior wall fibroids usually do not lend themselves.
That is one of the prerequisites, that the fibroid has to be immediately below the anterior abdominal wall with no bowel or any scar in that site.
Correct. And follow-up studies have found that sometimes these patients will have some amount of bowel adhesions to the fibroid. The fibroid itself does not magically disappear. It gets liquefied. Maybe the volume is reduced, and you have to counsel your patient that subsequently when they undergo an MRI as a follow-up visit, that the fibroid will still be present. It's not going to vanish away. You are not Harry Potter, and MRI focused ultrasound is not Harry Potter's magic wand. So they have to be aware that their expectations have to be managed and appropriate. I'm going to now turn the discussion to something which is a new agent, and you can see it here on the slide. It's called Tripterigium wilfordii. I'd like to invite the panelists to give me their views, whether they have used it in clinical practice. Do they feel that it is something which they would like to try in the near future? Is it something which should be considered as part of our armamentarium?
Yes,
I read about
this.
Yes, Dr. Seema, go ahead.
Ma'am, please.
No, go ahead.
Madam will take that.
Oh,
Should I?
Go ahead.
I have been using this product very oftenly, and this showed a very good decrease in amount and symptoms of menorrhagia and pain during past years. But it has not showed the decrease in the size of the fibroid. But definitely there relief of symptoms were there, and we have been using this for past years.
So your personal experience is that it tackles the menorrhagia quite well. Maybe the size of the fibroid or the volume of the fibroid is not significantly lower, but patients have a relief of symptoms. Yes, Dr. Asha Janna, you were saying something.
Sir, I wanted to ask what is the trade name?
Fibronorm.
Unfortunately, I cannot take trade names here, ma'am. So let us not have that discussion here. Since we are on the Amox platform, we cannot talk about trade names.
No, sir. Actually, I just wanted to know. I have not used it because when it was shown to me and I read about it, it is, sitting on the fence. It is not, there are some papers, the total study is only on 2,200 people, and that includes 21 studies. And in that also, it is, it's literally on the fence. That some say, yes, there is a response. Some say there is no response. So maybe we will have to organize our own trials. But as things stand, especially in private practice, I would not dare to give it to a patient and then see no response. It reflects really bad on you.
Okay, so let me just lay the entire controversy to rest. We've discussed a lot of medical management for this patient. Classically, we talk about in our textbooks, GnRH agonist, we talk about Mirena, which we've covered earlier. Obviously, you need something to arrest the acute episode, and that would include the other agents which are listed here. SPRMs are something which have come of age over the past 5 to 10 years. The most common SPRM which we use in clinical practice is mifepristone, ulipristal acetate, as we've already discussed. Unfortunately, is no longer available because of the ban on the drug. And all of these agents can give you a reduction in myoma up to 30%. Now, the word up to is very important. Just like you go to the Amazon and Flipkart sale, it will say up to 50% and 60% discount. In practice, you will not get a discount of more than 1,000 rupees. So please be aware that this is the maximum reduction in size that you can expect. As far as the reduction of symptoms is concerned, as far as the reduction of menorrhagia or heavy menstrual bleeding is concerned, that can be significantly better than the reduction in the size. In fact, if you look at the most recent Cochrane meta-analysis on SPRMs, it says very clearly, and this is published in 2017, that there is significant improvement in the fibroid symptom severity. There's also improvement in what they call health-related quality of life, and they have various ways of assessing that. This is something which is important when you read research papers. They talk about QALYs and quality-adjusted life years. If you've read research papers, this will ring a bell somewhere. But the take-home message is that there is a significant reduction in menstrual blood loss, and there are also certain patients who complain of amenorrhea. So you need to warn your patient beforehand that giving these medical agents can result in the period ceasing completely. Now, if you have a patient who's from a good class of society, she's educated, she's Google savvy, she has her own smartphone, she will discover all these things by herself. You need not counsel her extensively. The problem comes when you are catering to somebody who's not from a very good class of society, they're not very Google friendly. So you will need to mention to them that you may have intermittent spotting, you may have amenorrhea, and religious issues which patients often have can sometimes negate the benefits that all these agents will offer. There are some RCTs regarding bilipristal and leuprolide acetate, and the effect of both seem to be the same. We are not going to discuss bilipristal. As we said, it's already not available now. As far as mifepristone is concerned, there is a very good Cochrane meta-analysis which was published. Unfortunately, it had a very small number of participants in the trial. The advantage with mifepristone is that it gives you excellent control of bleeding. It's very well accepted by patients. There is good compliance from the patients as well. And as I said earlier, you will need to warn your patient that the fibroid volume will not significantly decrease. So mifepristone and tripterygium are not Harry Potter's magic wand. They will give you relief of symptoms. But if you are expecting that the fibroid will vanish on the next ultrasound or MRI, that is not going to happen. The fibroid will still be there. Maybe the size will be a little more. This is the original European Medical Agency advisory regarding bilipristal. As far as tripterygium is concerned, it inhibits both estrogen and progesterone receptors. It's also known to specifically decrease anti-apoptotic factor BCL2 and increase the apoptotic factor caspase 3. It also inhibits aromatase enzyme. It can cause a reversible amenorrhea, and that is something which again you need to counsel your patients. In short, it is functioning like a GnRH analog, and patients who have taken this have reported decrease in menstrual loss by as much as 200 ml, which significantly adds up cycle after cycle. It also increases the hemoglobin levels by up to 2 grams per cent. There is a reduction in fibroid volume, and this may be variable. Various studies quote between 27% to 68%. There is also a decrease in uterine volume by up to 60%. Where estrogen progesterone receptor levels and the levels of the hormones themselves are going to decrease because there is competitive inhibition. And within up to 3 months of stoppage of therapy, you can expect that cycle regularization will take place. Whether this is right for your patient, whether you should advise this in your patient, is something which is between you and your patient to consider. There is no guidance. There is no international authority which recommends this or recommends against it either. If you have a patient who needs something to tide over a short crisis until she becomes fit for anesthesia and surgery, these are agents which you should take into consideration and offer to your patient with the appropriate counseling and documentation. Let's go to the next case. This is a 33-year-old lady. She's trying to conceive since 4 years. She has recent onset excessive bleeding, which is not responding to medical management. Obviously, she's going to require surgery. She has a 5 centimeter large fibroid, and this is indenting the endometrium. Dr. Seema, how would you like to operate on this patient? We are not going to engage in the discussion of whether surgery is required. Obviously, she requires surgery. Now, which surgery are you going to perform?
Definitely, she requires surgery, and
Yes.
go for because she's trying to conceive since 4 years, and she's primary patient, so we can advise her laparoscopic myomectomy.
Okay, and how would you go about doing this laparoscopic myomectomy? Anything you would like to add regarding the preoperative preparation, the actual surgery itself, and the post-operative myomectomy?
We would see her status fit for anesthesia. We will evaluate for her general systemic functions, investigations like complete blood count, and other investigations also like thyroid and LFT, KFT, for preparing the patient for anesthesia for going to the surgery.
Okay. Dr. Joy, would you like to take up the discussion? We've discussed the pre-op investigations. Do you want to talk about the actual intra-op procedure?
So can we consider her for selective progesterone receptor modulator followed by surgery so that the size of the fibroid may get reduced, and also the planes are well visible? So and also the blood loss may reduce. So we can convince the patient. And always
I think this was mentioned a little while earlier by Dr. Dipali. I'm sorry to interrupt.
Yeah,
when she talked about sandwich therapy by Richard Godet, and that's one of the options that's available. Yes, preoperatively you can give GnRH agonist
and we can convince her.
Agents like that until she gets ready for surgery. Let's talk about the actual surgical procedure itself. Does someone want to talk about that? Dr. Joy, you want to continue?
Sir, I think Dr. Dipali should take this question. She will answer it properly rather than me. So I will definitely pass to Dr. Dipali.
Okay, question is passed to Dr. Dipali. You are in the relay race and the baton has come to you.
So since it's a FIGO3 type of fibroid indenting the myometrium, so a laparoscopic myomectomy would be a preferable surgery as compared to an open myomectomy. So we have to see to it that the intraoperative blood loss should be less at the time. So there are various methods we can use for reducing the intraoperative blood loss. First of all, either you preoperatively give some medicines. If that is out of question, then we use a Boney's myomectomy clamp in our institute. So around
if it is an open surgery, yes.
Yeah, it's an open surgery, yeah. And in laparoscopic myomectomy, what we can do is we can use vasopressin in dilution, 20 units in 200 ml of normal saline. So the dilution comes to around 0.1 unit per ml. So that is the recommended dilution is around 0.05 to 0.3. Beyond that, it leads to a lot of side effects, and it is contraindicated in patients with hypersensitivity to this or an MI patient. So we have to be careful that whenever you are injecting the vasopressin, we are aspirating it and seeing that whether it is going intravascular. So vasopressin helps a lot. It leads to blanching of the tissue, and your dissection will be bloodless at the time of the surgery. And so yes, after giving the so it's an anterior fibroid or a posterior fibroid, that information we don't have. So incision,
we don't have that information.
You get a proper, as soon as the incision is given, you get a proper plane between the capsule. You reach the capsule, you just do the dissection, and scissors are preferred over electrocautery in doing the dissection. A myoma screw can be used, which will help in further giving traction and further. It will be difficult to use a myoma screw in patients who have degenerated fibroids. So in that patients, maybe a tooth forceps or something can be used. And so that's how we do. And since it's a single fibroid, what we need to do is the dead space occlusion has to be proper.
Correct.
Either you use a number 1 Vicryl, PDS, or the BAP sutures can be used if you don't want to take that hassle of taking knots. What we use in our institute is number 1 Vicryl. So dead space closure should be proper, perfect hemostasis should be achieved at the time of closure of the myoma bed. And on the serosa, we have to see to it that the suture material, less amount of suture material should. So you either take a baseball sutures, or if you're using a BAP suture, the knots will not be there on the surface. So that should help in preventing further adhesion formation. And other anti-adhesive measures, like you can use a Surgicel or Intercede, which can be put on the suture line to prevent adhesion formation.
Okay. So all that is very beautifully covered. Thank you, Dr. Dipali, for taking that up. I think, unfortunately, Dr. Santosh Hughes, our endoscopic surgeon, is called away by emergency. Therefore, you could not take this up.
I would like to
for the
ask Dr.
benefit of the
Dipali.
viewers.
Sir, sir, is there any role of laparoscopic occlusion of uterine vessels or vaginal? I was going through some papers.
Yes,
and
yes. Endonot.
Oh, yeah.
So the same principle which we used to follow earlier in open surgery, using a simple red rubber catheter in open surgery through a window.
It is put there through a laparoscope. It is put.
Similarly, it is done with a telescope.
Yeah, you occlude the uterine vessels as well as the ovarian vessels, madam, to reduce the intra blood loss.
And the advantage is that because you have the telescope inside, you have a nice zoomed in view, so you can find a nice window which is avascular and cause less harm. Sometimes in open surgery, you may not always be able to identify that. That may give you troublesome bleeding later on. So thank you for bringing that point up, ma'am. Yes, ma'am. Can I ask Dr. Nitumori to contribute a little to this discussion regarding this pitresin? Do you think that it should be used now in modern practice? Because so many countries in Europe have banned vasopressin. It's not available. You will need to unmute.
Am I audible now?
Yes, ma'am. Please go ahead. Please go ahead.
Yeah. So in instances where we cannot use vasopressin, we can use the other modalities available to decrease the bleeding during surgery. Preoperatively, we can use misoprostol 1 to 2 hours before the planned surgery. Vaginal misoprostol application will decrease the blood loss during surgery. And then we also do have the option of putting a tourniquet. So that should be, but the occlusion time should be like not more than 20 minutes. So we can, if at all we are taking a longer time for surgery, that we can do intermittently, we can release the tourniquet. This is to prevent the tissue ischemia and buildup of the toxins, which leads to tissue necrosis. So the other method of decreasing hemostasis would be, we can also start on with an oxytocin lines. So 10 units of oxytocin we can infuse to decrease the hemostasis. So I think these are the modalities we can use to decrease. And as Madam said, another method is that when we use a selective progesterone receptor modulator beforehand, we have a better hemostasis while surgery. But I think one thing about using selective progesterone receptor modulator before surgery is that the plane of the dissection between the myoma and the normal tissue becomes a little bit blurred. So surgery might be a little bit difficult in these cases.
So I think that covers all the various different options that we have. As a surgeon, it is important to remember that the final goal is what is important. Many roads lead to Rome. If you have only one road, then you will make a very poor surgeon. Know all the alternatives and be mentally prepared before you go in. I think sometimes it's really important for us as surgeons to understand what are our limits, to recognize that there are certain cases where we may require help. And ideally, that help has to be present inside the OT and on standby before we even anesthetize the patient. So you put in the telescope and face the complication, there's no point in running around like a headless chicken and calling. Yes, ma'am.
Another point I would like to make is that the inpatient should be preferably a transverse one over the uterus.
Yeah. Okay.
So that's an important point, I think. So that we do not cut the blood vessels and land up in more bleeding while doing surgery.
Try and be as avascular, try and take your incision in as avascular a place as possible. We have over 500 viewers. I've just been informed that we have about 550 viewers who are logged in. And they want to ask Dr. Rekha Rajesh ma'am, what is this aqua dissection? A lot of these endoscopic surgeons talk about aqua dissection. What is this new concept?
Sir, I think I'm not very sure about it because I don't do that much. Yeah.
All right. But have you heard of it?
Yes, I heard of it, sir.
All right. And what does it entail?
Sir, actually, aqua dissection is when you just put in a lot of normal saline.
Yes.
Everything gets, swollen up and the planes become much easier.
Yeah.
And because the small blood vessels are compressed, so there is no bleeding at the time. So this
As we
is
used
perfect.
to do in
So this is
vaginal.
one of the
mostly vaginal
alternatives.
hysterectomies. It's being
Yeah, you
used
can
a lot
also
in
use it
vaginal
for
hysterectomies.
laparoscopic myomectomy. This is one of the alternatives for conditions where either you don't have access to pitresin, or if pitresin is not available in your area, or if the patient actually is somebody who you fear that may end up with complications. And that is almost any and every patient today. So we've covered a lot of ground here, and we've talked in detail about laparoscopic myomectomy. I want somebody to tell us about the basic principles of an open or exploratory myomectomy. Can somebody
The
please cover
principles
that?
are the same. The principles are
Alright.
totally the same. The surgical
Okay.
principles do not change. So
Alright.
you open by the incision, which gives you proper, where you can actually deliver the uterus, visualize your area where it is. Then maintain homeostasis by one of the various methods that we have discussed. Give the incision, take it out. And most important is don't try to breach the endometrial surface. The endometrium should not be breached. And the other thing is that the closure has to be proper, because if there is dead space, the woman bleeds, and you feel you've put some method, you put vasopressin or aqua dissection, or you tied it at the time. So at that time, she doesn't bleed. But once you are out and she comes back to normal blood pressure, suddenly you find the patient has got pale dikh rahi hai, and you find that she has collected a huge blood clot. So the basic principle remains that the dead space should be very carefully obliterated, and hemostasis has to be proper. That's it. Means it's the basic principles are the same whether you do it laparoscopically or you do it in an open surgery.
I also
And
would like
one more
to-
thing, that in an open surgery you get the tissue intact, so please send it for histopathology. Even if it comes leiomyoma, please send it for a histopathology.
So then
Any tissue? Yeah, go ahead.
avoid multiple incisions. Like, if you have a patient of multiple fibroids, a tunneling incisions, like you go from the base of the fibroid to the next fibroid.
Correct.
And the
Excellent
fibroid which is reached last should be, that cavity should be closed first. And the other thing is, so myomectomy, if you're using a myomectomy clamp in an open surgery, while closing the defect, you should open the myomectomy clamp at that time when you're closing the defect to see for any active oozers anywhere.
Thank you, ma'am. Dr. Seema Varshini, ma'am, I wanted to ask you,
the ureters.
do you still do? Yes, Dr. Rekha, go ahead.
Yeah, see, if it's a very big fibroid or with distorted anatomy, the ureters need to be identified earlier and planned in such a way that you avoid handling the ureter or disturbing it.
Especially if it's a low uterine fibroid or a cervical
Cervical
fibroid, that's
fibroid
one of the
and,
most important precautions that
yeah.
we take. Thank you for breaking that up. I wanted to ask Dr. Seema ma'am, do you still do open myomectomy anymore? कि वो ज़माना भी चला गया. सब
नहीं
laparoscopy
sir,
से
in
करते हैं.
institute we do, sir. Still do open myomectomy, sir. We are in institute, we have to teach graduates everything related to, we also practice open myomectomy, to be honest.
So I think case selection is very important. Good counseling preoperatively is also equally important. And finally, as I said, as a surgeon, we should recognize our limits, whether it's an open surgery or a laparoscopic surgery.
Sir, literature
so
says
we have good help.
literature says if myoma is more than 10 centimeter, you shouldn't go for laparoscopic approach. But it is still dependent. It depends upon.
So 10 centimeters is something which is probably applicable to 100% of all surgeons. And between 5 and 10 centimeters probably will vary with the expertise of the surgeon and the place where he or she is operating. I don't know if you are aware, in Bombay and many metro cities, endoscopic surgeons are ghost surgeons. They come after the patient is anesthetized, they operate and they leave.
And go. Yeah.
They leave before the patient comes out. So the patient never knows who has operated. Sometimes the surgeon himself or herself will not know until he has put in the telescope what is the actual consideration inside, how many fibroids are there, there is no fibroid mapping. You are completely like a mercenary operating.
Very true, sir.
And that is why we need to cover all these important points when we are talking about a panel. because not everybody operates in an ideal situation. Not everybody has access to an entire team. Not everybody has access to a good anesthetist who's skilled at giving anesthesia for 3 hours, 4 hours, which your surgery may take if there are multiple fibroids. And in that compromised setup, we have to try and do the best for our patients. Anybody wants to talk about BAP sutures, and we'll close the discussion after we have talked about BAP sutures and move to the next case. Anyone can take that up. No experience?
Dr. Dipali, I think, should answer this. And I don't have any experience.
Okay, so then as the endoscopic surgeon left in the panel still standing, I will be the one to talk about it. BAP sutures have unidirectional barbs, which help some lazy surgeons like me to close the incision very quickly and ensure that your incision is closed before the effect of your pitressin has worn off. It also ensures that you get good apposition. There are two ends to this suture. So with one, you can do the inner layer. With one, you can do the outer layer. Ensure that your dead space is completely obliterated. Anywhere where your incision is more than 3 or 4 centimeters in size, it is always recommended to close in 2 layers. You can also use a baseball stitch with inverting sutures so that the surrounding tissues like omentum and cord don't come and stick to the side of the suture line. The advantage with this is that it can be completely sutureless. All your suture material is completely buried and there is no hematoma formation subsequently. Usually I like to recommend that we always put a drain inside. Many surgeons don't like to put a drain, but whenever you have a large myoma, it can be advantageous to leave a drain like a 32 or a 28 French to the right or the left lower port, and that can be removed after 48 hours. That helps in reducing the amount of adhesions also, because no matter how well your suturing is, ultimately there may be some amount of collection, and putting in a drain helps to prevent post-operative adhesions. I think this is our second last case. So we'll quickly move to this one. 38-year-old seeking treatment for menorrhagia and infertility, severe dysmenorrhea, abdominal pain, 5 centimeter anterior wall fibroid and an ovarian cyst. And this is the classic case of the host surgeon who has come to operate in a small nursing home where there are no backup, there is no facilities, there is no portable ultrasound, kuch bhi nahi hai. And when your laparoscopic myomectomy was taking place, you found that the plane between the capsule and the fibroid was difficult to deal with. Whether this is because preoperative region agonist was given or there is some other pathology that we are dealing with here. Dr. Ekta, you want to start the discussion?
Yes, sir. This could be an adenomyoma too. So
okay,
maybe that is why the plane has not been delineated. Sometimes we do see situations like that, and if the ultrasound has not been proper reporting of the ultrasound also wouldn't have happened, or the differentiation between a fibroid and an adenomyoma would not have happened. So in these cases, it is possible. So to that
an adenomyoma is a distinct possibility. Dr. Joy Agarwal, ma'am, before you put your foot in it,
yes,
in such a difficult case, what should be the basic precautions that all of us should take so that this does not happen to us?
As you have been emphasizing on informed consent. So when I have limited resources, I don't have good jumping on doing a laparoscopic, say, myomectomy, I have to counsel the patient regarding that you have you are seeking for infertility. It's a risky surgery. It can turn out to be anything during surgery. Land up in having even hysterectomy in such cases. You may land up in that, and it may be some different pathology as well. We'll try our best, but you have to take that. So that is very important thing which you have to do before planning a surgery, of course. And during the surgery, again, you have to, during the procedure, patient's attendant should be informed regarding this, that see, we have not found a myoma, but there is some pathology other than myoma may be present. We need to remove it since she is having infertility and also AUB. And at times it may, if you consent it, we can proceed for removing, or we may abandon the procedure. So everything has to be informed, and you can proceed with the adenomyomectomy as well if it is there.
So thank you for highlighting, ma'am, that we should prepare ourselves as well as the patient equally well. One clue here is that she has an ovarian cyst along with the so-called in
Can
inverted
be
commas
correlated
fibroid.
with this thing. Endometriosis can be there because of
Correct.
patient is having
Absolutely.
severe dysmenorrhea and abdominal pain. And
But the problem is, whenever the nursing home owner calls you on the phone, they don't tell you कि ovarian cyst भी है, because उनको लगता है फ्री में आप ovarian cyst भी कर डालोगे, आपको खाली fibroid के बारे में पता है. It's only when you put in the telescope that is when you feel it. So this is something that we should, as surgeons, ensure that we know all the details about the patient. Finally, we are the ones operating on the patient, even though we may be ghost surgeons. We are still responsible for the patient's well-being and ensuring that there is good success at the end of the surgery. Don't just look at it from a mercenary attitude. Feel responsible for whatever you are giving to the patient and should result in a good positive outcome. Dr. Asha Jain, ma'am, would you like
Sir,
to tell us what
I
should
am
we
just
do?
guessing, sir, how can we
that you need to actually do a very good quality ultrasound. A
Yes.
good quality ultrasound will tell you that it is an adenomyoma or it is a fibroid. That is one. You will have that preoperative diagnosis. If that fibroid is going into the phase of leiomyosarcoma, also the loss of plane can be seen beforehand along with the abnormal vasculature on Doppler. Number three, an ovarian cyst doesn't tell you anything. A 4-centimeter ovarian cyst, it could be a simple follicular cyst, it could be a mucinous tumor, it could be a serous tumor, or it could be an endometrioma. And an endometrioma has very, very distinct features. Sometimes both fibroid and ovarian anovulation are hyperestrogenic states. So, because there is a hyperestrogenic state, the patient has not ovulated. So, it is a retained cyst, a follicular cyst that is there, along with a leiomyoma. So, a good quality ultrasound with Doppler, with a 3D, is going to give you all the information before you get into this. So, if you have that information, then you would actually not land in such a situation. You would be prepared for it. Because if you cannot find the borders, if the borders are not clearly delineated, I have had a patient who had a leiomyosarcoma, came for a simple myomectomy, and we said, no, you require a complete removal. We completed the surgery and it turned out leiomyosarcoma. Of course, it was a 20-week size uterus. But the basic thing is that you can really make out what is wrong if you do a good quality ultrasound. And MRI is less useful than an ultrasound because MRI doesn't give you the doctors.
Very good. So basic principles, fibroid mapping, whatever investigations possible, make sure that they are there on paper. Ensure that you get a second opinion if you suspect that there is something wrong. Dr. Julie Agarwal, ma'am, you were saying something. Please go ahead.
I am just speculating whether ultrasound will be effective in such cases. I don't know. I'm just guessing.
I have trained under Gynec Academy, and you really learn how it is done. It can be rest assured.
If you get trained by a good radiologist, they'll be able to identify with these new probes that we have available. The consistency, the amount of fluid volume, exactly what is the extent, and what is the echo texture. All of that translates very well with these modern probes which we have. Purane zamane 20 saal pehle ke jo probes the, they used to not be able to identify that. So if you are in a tertiary institution where you don't have access to all this, maybe you should refer these patients once or a second opinion. It will reward you. Even one patient of this kind of clinical scenario, if you are able to prevent, it will be really worth it.
And if there are bowel adhesions, even that can be made out by the ultrasound itself, by the fat standing.
True.
So,
Dr. Dipali, your thoughts on this?
So probably this is a patient where, the planes are not well defined and aqua dissection would help.
Yes. So let's quickly go to the theory and the evidence as it stands. This is a very nice paper on uterine adenomyosis and adenomyoma. If you do enough fibroids, you will realize that some of them are adenomyomas, and very rarely you may even come across leiomyosarcoma. Hence, always send tissues for histopathology. There has been one case where an anesthetist was not diagnosed as having leiomyosarcoma. Morcellation was done, and unfortunately, because of that one case, the entire morcellation procedure and the instruments which are used for morcellation have been banned by the US FDA, and now they are going backwards.
I know many patients who have died because leiomyosarcoma was not diagnosed, and they went for that, subah jao sham ko chutki wala, they went for those kind of laparoscopy procedures, and a doctor friend of mine, uski mami, she had a leiomyosarcoma and she died. So this is happening everywhere, and I think it is time that we put a stop to it in India also. Not going backward, because the woman who dies 100%.
So we need to try and ensure that we tick all those check boxes, we cover all the basics of preoperative preparation, the absolute basic surgical principles while we are operating, and ensure that we try and give the best possible results. Yeah. Of course, these pictures and these illustrations talk about open surgery and how you can do a wedge resection, how you can pour out the adenomyoma, and there are different ways in which you can make flaps achieve the best cosmetic result, especially if the patient is desirous of fertility in future, or you are afraid that the patient may conceive and then land up in complications. This is a very nice paper which I found, and you are free to write to me about it. I'll be happy to share it with you by email. This is the last case now. Here there are multiple fibroids. This particular patient is afraid that it may turn out to be a cancer. So I think this is ideal for Dr. Seema to counsel her. How do we counsel her? How do we plan her surgery?
Sir, we will...
So let me start by asking, what surgery should we perform? Should it be myomectomy? Should it be hysterectomy? I asked you this question very specifically because you mentioned something a little while ago which I remembered.
Of course, sir, we would go for the hysterectomy, and she has multiple fibroid, and so we can go for abdominal hysterectomy, and we generally do it. And we will counsel her that it is not going to transfer in malignancy. That is very, very rare, less than 1%. And hysterectomy will be done. And what else?
Okay, so where childbearing is complete, and as we said, in Indian patients, often the fear is that कल cancer हो जाएगा, fibroid वापस आ जाएगा, period अभी बंद होने के लिए 10 साल बाकी है. So please, doctor, take it out. I don't want it anymore. That is the attitude that most Indian patients have. In contradistinction to Western countries, where they feel that an organ should not be removed unless there is some clear-cut indication. In Western countries, they will tell you, doctor, it's okay, I'll take medical management. I don't want to undergo surgery. My insurance does not allow. It does not pay me enough. I will not be able to afford the surgery. The scenario is completely different. So let's quickly talk about what the key issues here are. Since we know that this is a patient who is now 42 years old, anesthesia fitness is very important. We need not take it for granted that every patient who is undergoing a myomectomy or a hysterectomy is going to be fit for surgery. We need to talk about the incidence of leiomyosarcoma. We also need to ensure that it goes to a good histopathologist who is going to take multiple sections and ensure that leiomyosarcoma is not missed. The final question that I want to put to the panel is whether oophorectomy should be done at the same time as a hysterectomy. She's 42 years old.
Oh, no.
In the old days, we used to say leave one ovary. How has this teaching changed now?
Both ovaries. Leave both ovaries. Take out both the tubes.
Yeah.
Take out both the tubes.
Complete your uterus and the whole cervix as well. Don't do a subtotal hysterectomy.
Dr. Dipali, you're in a teaching institution.
So
Could you tell us your views, please?
So even we follow the same. She's 42, so she's at least 9 to 10 years for her menopause. Why should we push her into premature menopause? We will conserve the ovaries if they are on ultrasound, they are normal, and when we see introp, if they look normal, we will conserve the ovaries, remove both the tubes and the uterus.
Well, we should take the we should counsel her properly, sir. I had a patient. She had gone hysterectomy at 42 years like that, and now she has come with pain abdomen, and I got her ultrasound done. Then I found a very big 8 centimeter ovarian cyst is lying in the pelvis, and so we should counsel the patient about the pros and cons of leaving the ovaries or not. And
sir, this is a small town story, sir. Yes, sir. This actually happens in our institute also. A poor patient coming to us from remote areas. Okay, they get hysterectomized and then they say, "Aapne to aadha operation kiya."
Yes,
now the tumor is again here. So it's like you have to counsel. They don't realize. Still, I mean, menopause is so much neglected, and they don't realize what is the consequence of being surgically attaining surgical menopause and so early. I mean, they don't actually realize. It's really very difficult to counsel these patients.
So yes, the problem is, if you remove the ovaries, you are in trouble because you have caused a surgical castration. If you leave the ovaries and tomorrow the patient lands up with an ovarian cyst, you are blamed that you have not done a complete surgery.
Right.
And like the old days teachings, if you remove one ovary and leave the other, there is no guarantee that the ovary which is left behind is not going to have complications later on in life.
Very right.
So whatever you do, ultimately you are responsible for whatever happens after your surgery, even though it may not be related to your surgery in the first place. So we are living in a very difficult era. We have to counsel our patients appropriately. We have to ensure that they are provided all the information and they are the ones who make that decision. This is the message that I want to give everybody. We don't decide for the patients whether ovaries are to be removed, whether they are to be kept, whether you remove one and you keep the other. Let the patient decide, document it clearly, ensure that a proper consent is there on paper, and then proceed for your surgery. The era where we used to make decisions for patients is now over. We are living in an era of litigation where even 5 years, 10 years down the line, patient who has undergone hysterectomy may say that I got a myocardial infarct because you removed both my ovaries and now I am menopausal. You never know, that might happen. We have to unfortunately be prepared for even those kind of situations. So we've had a lovely panel with several eminent stalwarts from all over the country. There's only one last question that I want to ask, and unfortunately I have not put up a case for that. And it's something which is interesting, which we should talk about when we talk about fibroids. And that is whether if you encounter a fibroid at the time of cesarean section, क्या करना चाहिए? निकाल देना है कि छोड़ देना
है?
नहीं निकालना है. नहीं निकालना है.
Recently posting one patient, I have to remove if it's on feasible position, if it's subserous, remove it. There is no harm.
I had a patient. It was present. It is around like this thing, lying at the incisional side, and I had taken out, and she bled profusely, and I had to do subtotal hysterectomy, and she was gone case, but she came back by taking a blood transfusion. Our anesthetist gave her, and ultrasonologist was there. He has given the blood transfusion, and we got arranged 5 to 6 bottles. Then we could save.
Actually, madam, it all depends upon the location of the fibroid.
Very.
So you have to decide intraoperative fit or not. Not always. It's not a.
Right, very rightly said.
So, Dr. Eka Rajesh, any views on this controversial matter? If you find a fibroid during cesarean, should you take it out or should you leave well enough alone and not interfere?
So, like Madam said, depends on the location, the vascularity, and the assessment, clinical assessment for us, whether it is safe to take it out. If otherwise, I think we can give it some time and she can come back for a laparoscopic myomectomy a little later. But I have done 1 or 2 myomectomies on table during section because it was obstructing the cavity and it had grown inwards. But we've had the same issue where she had a heavy bleeding and but we managed to take care of her and she's settled. But yeah, the location matters, the vascularity matters, and the situation on table matters, sir.
Sir, I
So
have a
let's hear
patient.
from Professor Dipali. What is her view? What should we do?
So-
मार दिया जाए या छोड़ दिया जाए?
Sir, if the consent is not taken, I would not remove.
Excellent point.
Yes, so and one more thing, my boss, Dr. Praveen Matre, he used to do a lot of cesarean myomectomy when I was a resident in Vadia. But yeah, obviously prior consent used to be taken, and his surgeries are beautiful. So the hemostasis used to be perfect, and yeah, prior consent was always taken for a cesarean myomectomy.
So the two important points here, which I think the entire panel wants to convey is, if there is a consent on paper, that is when you operate. Number two is, if it is interfering with your surgery and there is no way to avoid it, then you go ahead and do it. But again, you need to have a consent on paper. Number three, ensure that you are operating in a place which is not like a small nursing home where you don't have blood and blood products available, where you don't have a helping hand. If you are in that kind of situation, please transfer this patient to a larger institution where all these facilities will be available. Even the smallest looking innocent fibroid in a pregnant patient can give you grief, and you don't want to land in that situation. So let's have some closing comments from all the panelists before we close our panel. We have finished, I think, well in time. We have about 10 minutes. If there are any audience questions, we can take them. But I would like some take-home messages, one final take-home message from each of the panelists before we close. We'll start with Dr. Juhi Agarwal, ma'am. Anything that we have not covered so far which you want to convey to the audience? Please, Anju.
Sir, as a concluding remark, sir, thank you so much for making me part of this panel. And I have really enjoyed with such lovely panelists and also an expert moderator. And the take-home message which I want to give in this panel is that never panic whenever you see fibroid. Always counsel the patient beforehand, before proceeding for whatever you want to do, whether surgery or medical management, whatever. So fibroids are really benign tumors, and let them remain benign as far as counseling is concerned. So that is my take-home message.
Thank you, ma'am. Dr. Eka Rajesh, ma'am.
So I'd like to say that, many people feel fibroid, as soon as we say fibroid, they think it's a tumor, it's malignancy, and, I'm going to die the next minute. And then they go shopping and visiting multiple doctors. What we need to do is build confidence and tell the patient that this is not the end of the tunnel and we have hope. And if the sizes are not very big, we can do conservative management. And it depends on how we counsel the patient, where she confides in us and takes our decision and supports us in the conservative management. Like otherwise, like Madam said, it will sit in their head saying, I need to get a surgery and I need to get hysterectomy. And hysterectomy is not the first choice for fibroids, is what I need to tell everybody. And even if it's the patient's demand, we should take that little extra step to counsel the patient and hold them and try to push it as far as possible. I keep them in regular follow-up, call them once in 6 months, tell them, do a scan and tell them it's not growing, and then rebuild their confidence and tell them that medical management is possible. And I think we should look towards medical management in these patients.
So good one-to-one relationship with the patient, confidence building measures, appropriate counseling regarding medical management, and only a surgery as a last resort in carefully chosen patients. Good points, ma'am. Dr. Seema Vaishnavan, anything you would like to add?
Thank you, Dr. Pratik. And I have enjoyed and I have learned a lot today with esteemed group of panelists. And ultimately, we have to counsel a patient when she comes with fibroid. She is very much scared, and we should counsel her with tender love and care, and we should build the confidence in her that you are not going to die, and this is not going to turn into malignancy. And first, we will try for medical management, and if needed, you better go follow up with ultrasound and doctor's consultation, and if required, then surgery can be the treatment. And there are a lot of medical management, and if not relieved, then we will go for the surgery.
All right. Thank you so much. Dr. Asha Jain, ma'am, as the senior expert on the panel, any take-home messages? Then we'll need to unmute, please.
Thank you, sir. Thank you for having me here. And I've really enjoyed the discussion and even I learned a lot. So my take home is back to an ultrasound that a fibroid is a fibroid only when you really are able to pinpoint that this is a fibroid. Whether it is going to have symptoms or not will depend on the location, on size, and its relation to other organs. A huge subserous fibroid anteriorly might cause recurrent UTI. A big posterior wall fibroid, which is subserous, may cause constipation because the patient is unable to, normally pass urine expressing on a rectum. So we need to diagnose correctly and then be convinced ourselves that fibroids are benign tumors and not every fibroid needs a malignancy. And many people just look at the fibroid, a chance finding on an ultrasound in an asymptomatic patient who's gone for a yearly check as an opportunity. So we need to convince ourselves that not every fibroid needs surgery, and then we can put it across the people. So a correct diagnosis and then appropriate.
Thank you, ma'am, for those wonderful points. We see Dr. Neetu Modi is back with us. Ma'am, any closing remarks before we close the panel?
So first of all, I extend my sincere most thanks to you for giving me this opportunity to participate in this esteemed panel. And I apologize for the horrible network here for which I was in between, could not participate. And so my concluding remarks about fibroids would be, fibroids are the most common tumors of the reproductive tract of female, and though they are not avoidable, and here we have discussed the vast modalities of treatment ranging from pharmacological to minimally invasive to definitive surgery. Still, I would like to advise women that they should adopt healthy lifestyles, and they should stay fit, avoid obesity, decrease the consumption of alcohol, increase the intake of fruits and vegetables in their diet, thereby maintain a good BMI and hence keep fibroids at bay. And so that would be my advice.
Thank you, ma'am. So good lifestyle modification and healthy lifestyle will ensure that even if you have a fibroid, you will recover quickly from your
surgery. However most possible. Yes.
Thank you. Dr. Dipali, any closing remarks, ma'am?
Thank you, sir, first of all, for making me a part of this esteemed panel of senior doctors. So my take-home message is definitive management of fibroids. Either it can be medical or surgical or a combination of both. But we have to individualize it depending on the symptoms of the patient, the size, the site, and the patient's desire for fertility or preservation of the uterus. That is more important. And yeah, explaining to the patient while counseling them the benefits and risk of every procedure, whether it is medical or surgical, is important while coming to a decision of what treatment you want to give to this patient.
Thank you, ma'am. So thank you all our esteemed panelists for a fantastic panel. I see Dr. Santosh has been unable to join us, so we express apologies on his behalf. I would like to close today's event by offering the following vote of thanks. My gratitude to the AMOG's office bearers, our esteemed President, Dr. Nandita Palshetkar, Secretary of AMOG's, Dr. Arun Nayak, ICOG Chairperson, Dr. Uday Thanawala, the Secretary of ICOG, Dr. Ashok Kumar. Thank you for the ICOG credit point for today's event. Our fantastic panelists from all across the country, starting with Dr. Asha Jain from Raipur, Dr. Neetu Modi Gogoi from Assam, Dr. Seema Varshney from Ghaziabad, Dr. Jeswar sent her apologies, she went into a family emergency, Dr. Joy Agarwal from Bhopal, Dr. Dipali Kapote from Thane, Meri Gawali, so to speak, Dr. Santosh Jayapare from Navi Mumbai, and finally, last but not least, Dr. Rekha Rajesh from Hosur. Thank you so much for sparing your precious time and being here for 2 full hours in this wonderful evening of evidence-based medicine. Finally, I need to express my gratitude to the Science Integra team led by Subbu, Session and Simon. Thank you so much for being a scientific and academic backbone. And I should also say thank you to the Acumentis Viviana team, our academic partners, for helping us organize this series of events. And today's event has been focused on myomas, the most recent options and advances as far as treatment is concerned. Thank you everybody in the audience. We have nearly 550 logins. Thank you for joining us. Please download your certificate. If you refresh the page, you'll find a download button and you'll get your ISOG credit point certificate. And we hope to see you in the next one. Until then, goodbye, God bless, and stay safe. Bye for now.
Thank you, sir. Thank you, sir.
Bye-bye.
Everyone.
Thank you, everyone.
Bye-bye. Thank you, Dr. Pratik. Bye. Good
Thank you,
night.
Dr.
Thank
Pratik.
you. Bye.
Dr.
Sachin, you
Pratik,
can
you
take us off
always
here.
have more than 500 participants in each panel I have seen.